Welcome to AETCM, the Emergency Medicine channel.
Yeah, please.
49-year-old female, known case of diabetic dyslipidemia, presented to our ER with acute onset of upper abdominal pain, followed by multiple episodes of vomiting since 2 days. In initial 10-second assessment, patient was conscious and oriented, obeying commands, and able to complete one full sentence. In primary survey, airway, patent, no pooling of secretions, no gurgling or no hoarseness of voice.
Okay.
Breathing part, respiratory rate is 22 per minute, saturation is 96% room air, chest is bilateral equal air entry. Circulation bar BP 160 bar 80 millimeter mercury, pulse rate is 104 per minute, and all peripheral pulses are palpable and 2 large bore IV cannula inside at that time. Disability GCS E4, V5, M6, and the pupils bilateral equally reactive to light. Exposure bar temperature is normal, GRBS is 212 milligram per deciliter. She has a pain score of 7/10, so that time we give injection paracetamol 1 gram IV stat, and for vomiting injection ondansetron 4 milligram and pantoprazole 40 milligram injection we given. In adjoint to primary survey, first we take an ECG showing sinus tachycardia. Then we take point of care, CBC, CRP point of care, and VBG. CBC, CRP showing total count 18.9, CRP 185.9, hematocrit 50.7, and VBG pH is 7.4, PCO2 is 37, bicarbonate 24, lactate is 1.3, creatinine is 0.55, potassium is 3.8, sodium 138.
So what are the differentials you're going to consider at this point? 47-year-old lady presenting with abdominal pain, acute onset abdominal pain with vomiting. Further evaluation is showing while leukocytosis is there, CRP elevation is there, and hematocrit also you feel is borderline high, right? And no other positive findings, right?
ECG also there is sinus tachycardia.
No other positive findings, right? Okay, so what are the differentials you are going to consider in a patient coming like this?
In patient coming with upper abdominal pain, we're concerned about any with acute pancreatitis or commonly acute gastritis, cholecystitis, cholelithiasis, abdominal aortic aneurysms, dissections. Like features are we concerned about upper abdominal pain.
Okay.
Sudden onset of abdominal pain.
This patient is diabetic, no? Okay. Diabetic patient.
Diabetic ketoacidosis.
Medical causes of abdominal pain also you need to remember. Okay. Then reproductive age group. Again, think about obstructive causes. Okay. Right? Ectopics and things like that. Definitely you need to keep track of. Then
during secondary assessment.
No, regarding the abdominal pain itself. Anything else? Gastritis you told, pancreatitis.
Renal stone, appendicitis, knuckle diverticulitis.
Okay, fine.
Ovarian, female patient is ovarian torsion, you can suspect.
Yeah. Okay, fine. So that is with the various causes of acute abdominal pain. Then, so you initially gave what all you gave for abdominal
pain? For pain, injection paracetamol was given, and vomiting injection ondansetron 4 milligram is given.
Okay, we'll come to pain management and abdominal pain later. Fine. Continue.
Secondary assessment.
And also you have taken an ECG also. Basically, MI can also present like this, no? So you have ruled it out. Fine. Okay.
Secondary assessment. A 14-year-old female, known case of diabetic dyslipidemia, presented to the ER with acute onset of upper abdominal pain, which is continuous in nature and radiating to back, and pain decreases while bending forward and increases in supine position, associated with multiple episodes of vomiting containing food particles only. There is no history of any constipation, abdominal distension, fever, or decreased urine output. Clinical examination, there is no pallor, no icterus, no clubbing, cyanosis, or lymphadenopathy. In GIT examination, systematic examination, GIT examination, inspection, there is no scar, no signs of any visible peristalsis, no discoloration around the umbilicus and flank regions. Palpation, tenderness over the epigastric region. There is no organomegaly, no girding or rigidity, no rebound tenderness. Auscultation, bowel sounds are heardable, and percussion, tympanic notice. Other systemic examination within normal limits.
Continue.
Then we check for investigations. From primarily we are due to these symptoms like pain in the upper abdominal, radiation to back with multiple episode of vomiting. We are thinking about any acute pancreatitis, so we send.
Okay. If you are suspecting pancreatitis, what are the other 11 history you need to ask?
Any previous history of gallstone we can ask.
Okay.
Diet about the diet or in alcohol history. These are the most common thing. Alcohol and gallstone is the most common thing.
Okay.
In females, history of any OCP, taking hormonal therapy, like estrogen causes, uncontrolled hypertriglyceridemia, obese patients.
Any other drugs?
Some immunosuppressant like azathioprine,
Good.
paracetamol intake, or corticosteroid intake.
Other drugs which are notorious to causes? Not in this patient.
Retroviral drugs also.
HRT, heart. Metformin also there, it can cause. Okay. So this patient metformin was there or not?
Metformin for diabetes. Metformin.
There are case reports of metformin leading.
Metformin.
Yeah, metformin. There are case reports of metformin leading to pancreatitis. Okay, fine.
Our investigation part, we will check first of all lab CBCRP and CRP. Along with we check RFT to rule out any, because the hematocrit is 50, so patient is there is signs of dehydrated, so we check for RFT to pre-renal cause, anything is there.
Okay.
And LFT, along with LFT we check for amylase and lipase. Serum amylase and lipase, and also we check the
You can give the values. Yeah.
serum amylase is 2060 and lipase is 3643.
Okay. What does that indicate now in this background?
Acute pancreatitis is indicative. Then urea RFT, urea is 33, creatinine is 0.63.
Okay, so there is no overt renal failure kind of things. Fine.
LFT direct bilirubin is 0.8, indirect bilirubin is 0.62,
Okay.
SGOT 28.9, SGPT 39.9,
Okay.
ALP 74,
Bilirubin is also fine, no?
ALP 74. Total count is 18.9, CRP is 185.9.
So both leukocytosis and elevated CRP are kind of expected in acute pancreatitis. Fine.
Other thing, total cholesterol is 130.2, triglyceride is 64.1, HDL is 45.7, and LDL is 71.9.
Okay. Any other labs which is important in this scenario? Calcium.
Calcium is 7.67, magnesium is 2, albumin is 3.
Okay.
Corrected calcium is 8.4.
Okay.
These are the lab investigations.
You want to say how you calculate corrected calcium?
Corrected calcium, for every decrease in albumin, 1 decrease in albumin, we add 0.8 to the calcium, lab calcium.
Okay.
Then we do imaging study, USG abdomen and pelvis we do
Okay.
to confirm the any
Okay. So,
pancreatitis.
okay. Yeah, continue.
That show there is a peripancreatic collection. USG abdomen, edematous head of pancreas with peripancreatic fluid extending to the few hepatic spaces.
Okay. So do you really need an imaging to say it is acute pancreatitis as per the diagnostic criteria?
No, expert diagnostic doesn't need.
So all you need is 2 of the 3. What are the 3 criteria? One is your abdominal pain, typical abdominal pain.
Lipase
2
and
is amylase or lipase. How much increase? Threefold increase.
Threefold of the upper limit of the normal range.
So a threefold increase of amylase or lipase, and third is radiological. Okay, so any 2 is good enough to categorize a thing as acute pancreatitis. Fine. So ultrasound also here should, because ultrasound usually has a lot of limitations, like with the bowel gas, obese patient and all. Pancreas, to visualize the head of pancreas at times is difficult in an ultrasound. In those kind of patients, definitely, if the diagnosis is in dilemma, where you have a typical kind of pain, but your amylase lipase is borderline, and then you have a very strong suspicion, then definitely you will need to proceed with a CT of the abdomen. Fine. Okay, continue.
Then if rule out any necrosis or complication, we do CT scan also done for the patient.
In the acute phase, there is in such a case scenario, there is not much role of CT, to be very frank. Okay, CT once, because here the diagnosis is established, right? diagnosis is established from the other investigations itself. So you are doing a CT at this point need not change the management. Okay, if the patient is continuing to have persistent abdominal pain, not improving in post admission into the day 5, day 7 kind of scenario, that is where definitely CT will give us some information for which something additional needs to be done. At this point, doing CT is okay, CT will pick it up, but it need not influence the management. Okay, fine.
Then we do a chest X-ray and abdominal X-ray to rule out any, most commonly in acute pancreatitis, the left side pleural effusion is there, so to rule out any pleural effusion, and also abdominal X-ray to rule out any perforation, gas under diaphragm.
You told about pleural effusion, but what is the most common respiratory complication in acute severe pancreatitis? It's ARDS. Okay, fine. So those are the pulmonary kind of manifestations. Fine. So here we did the CT also. CT also confirmed. CT with contrast, right? So that also confirmed.
Necrotizing, pancreatitis.
But definitely we are getting some additional information from the CT. No, what is there is no obstructive kind of.
No obstruction. Only there is ill-defined peripancreatic collections. MPD is not dilated. There is no gallstone. Also, the intraparenchymal peripancreatic necrosis is seen.
Necrosis is seen. Okay. How long the patient has symptoms? Sorry.
48 hours to 2 days.
2 days only. Okay.
These are certified.
You want to talk about the CT severity score at this point?
Sir, CT severity index to assess the severity of the acute pancreatitis.
Okay.
It is sum of 2 score. One is Balthasar score. Other is pancreatic necrosis score.
Okay.
In Balthasar score, A to E, A is normal pancreas. We give score is 0.
Okay.
Enlargement of pancreas B, that is 1. C is inflammatory changes in pancreas and peripancreatic fat, it is 2.
Okay.
D is ill-defined single peripancreatic fluid collection is 3. E for 2 or 3 more poorly defined peripancreatic fluid collection is 4.
Okay.
That is Balthasar score.
Okay.
And second score is pancreatic necrosis. In first is none is given to 0, less than or equal to 30%, 2 score given. More than 30% necrosis and less than 50, up to 50 is 4. More than 50% necrosis we give 6.
Okay.
And sum of these 2 score getting the CTSA score.
Okay.
If the sum is
mild, moderate, and severe.
0 to 3 mild acute pancreatitis.
Okay.
Sum is 4 to 6 moderate acute pancreatitis. Sum is 7 to 10 severe acute pancreatitis.
So do you have the scoring for our patient? Like.
No, sir. This patient is for 10 is the patient because of necrosis more than.
So she'll fall into the category of severe pancreatitis. No? Okay. Continue.
Then manage.
Immediately, I mean, from the ER perspective, anything else for this patient? What are the other advices or orders you are going to write?
First of all, we put the patient in. Initially, we put a patient in NPO. Later, after 24 hours of admission, if the pain is controllable and patient can take comfortable oral feed, we can start oral feed as per new guidelines. If the pain is controllable, patient can take oral feeds.
Pain controlled, and what is other prerequisite for starting on feeds? It is nausea. Okay, patient has
nausea
to,
and pain is controllable.
Okay, patient is no more having active vomiting, and pain usually it will settle down, and what we need to look for is once you start the feed, then pain will come back. Okay, so you can start on short intermittent kind of feed. So one thing is you told about the NPO order. From here, definitely an NPO order is going to be on the chart.
Then we concerned about the pain management.
Okay, good.
We give pethidine or tramadol. We can give. Then fluid resuscitation is the main management.
There is no superiority of one drug over the other. Definitely opioids, paracetamol, and NSAIDs. NSAIDs provided there is no renal failure. Okay, all 3 drugs have been equally used. Okay, so any of these drugs to get pain control. So what if there is refractory pain in pancreatitis? Is there any interventions which somebody can do? Will be going for an epidural analgesic. Okay, definitely refractory patient post-admitted acute severe pain, not able to control. Then there is role for epidural analgesia. Okay, fine. So that is NPO, analgesia or pain control. Third,
aggressive hydration is the main treatment from our side. Initially, we give 20 ml per kg for the 30 minutes. That is followed by 3 ml per kg per hour for 8 to 12 hours the fluid management.
Okay. Regarding the fluid, none of these regimes have been proven to be significantly beneficial. Okay. So definitely this patient has other evidence of dehydration. Okay. So because of that, definitely a high volume initial fluid bolus is justified. Just because the patient is having severe pancreatitis does not warrant pushing the patient with lot of fluids. Okay. Definitely hydration is important, but go for a more conservative kind of approach. Hydrate, reassess. Okay. Because third spacing, again, other things are going to come up. Once you move into severe pancreatitis with ARDS and all, definitely further hydration will backfire. There is this concept of de-resuscitation also. So once you give a lot of fluids in sepsis or septic shock, after a certain point of time, we might need to decongest the patient. So the in thing will be definitely go look at other features of volume overload or dehydration. Go for your IVC assessment. If you have lines in place, use that as a tool to look for the volume status and then kind of use hydration. Okay. So that will be the key message will be to individualize the hydration for each patient. Okay, fine. So fluids again, what is preferred?
Mainly normal isotonic fluid like normal saline and ringer lactate is.
Okay, fine. So oral RNS we are starting. Fine.
Then we give advice to don't to take fatty diet.
No, acute things. Do you want to start the patient on an antibiotic?
No, only necrotizing or any complicated peritonitis is there when we start antibiotic.
Okay.
Otherwise, acute pancreatitis never need antibiotics. Only fluid management. And if there is suspecting any secondary bacterial peritonitis or necrosis like complication, we can give antibiotics.
Here we have evidence of necrosis. No. Okay. If at all you are giving an antibiotic, what group of antibiotics has the most evidence in acute pancreatitis?
Like meropenem, imipenem.
So it is going to be either carbapenems or fluoroquinolones. Okay, these are the two broad group of antibiotics which has evidence of being beneficial in acute pancreatitis, and most of the time we start with carbapenem only because lot of things will come in. What are the suspected organisms, the penetration of the drug into the pancreas and things like that. Okay, fine, good. Then continue. So we would have started the patient on fluids, glycemic control, right? NPO orders, analgesics, and admitted the patient, right? And you talked about the feeds. So you want to you also mentioned that it is better to start the patient on
low fat diet is
on oral or enteral feeds. No?
Feeds.
Okay. How are you going to kind of, what are the principles behind it? Why enteral? Why not parenteral? What is the alternative for enteral? Parenteral nutrition. No? Okay. So in between there was this concept of giving parenteral nutrition to pancreatitis patients, but now the gut health is also important. There is enough evidence to say that you can start the patient on enteral feeds. Early into the pancreatitis itself, maybe day 2, day 3 itself, you start the patient on slow oral feeds. If the patient is tolerating, then going upon on the feeds. So if the patient is conscious and oriented, definitely per orally is fine. If not, what are the options available? Is there any superiority of placing an NJ tube, nasojejunal tube, over nasogastric tube? Again, there was initially some school of thought saying that nasojejunal will be little more superior because it bypasses the area and places the food directly into the jejunum. But now it is both are equally good or equally bad. So NG or NJ is equally okay, because NG definitely you can place it blindly. NJ you will need an endoscopic placement and all. So NG is good enough to start on enteral feeds. And only when in very exceptional kind of situations where NG is not at all tolerated, recurrent thing is happening, recurrent intolerance is being documented, then only there is some role for parenteral nutrition. But of course parenteral nutrition comes with a lot of other additional risk factors and infection and things like that. Okay, fine. So that is with the feeds. Continue.
And then we can do some other bedside scoring system, like BISAF score. BISAF score is B for blood urea nitrogen, I for impaired mental status, S for SIRS, that contain temperature, pulse, respiratory rate, WC count, and A for age, and P for pleural effusion. If you CT is not planning to do, we can simply use BISAF score and grade the patient.
Again, mild, moderate, severe, or
So mild, moderate, severe.
Yeah. Okay. Then
Another score is Atlanta classification. Atlanta
you
classification.
now have the revised Atlanta classification. Okay. Yeah.
One is interstitial edematous acute pancreatitis or necrotitis acute pancreatitis. In interstitial edematous acute pancreatitis, acute inflammation of the pancreatic parenchyma and peripancreatic tissue without tissue necrosis.
Okay.
Necrosis is, there is inflammation along with necrosis of the pancreatic parenchyma and peripancreatic tissue.
Okay.
According to severity, we can classify to mild acute pancreatitis. That means without any organ failure, pancreatic inflammation. Moderate is transient organ failure less than 48 hours. Severe is multiple organ failure more than 48 hours of pancreatic inflammation.
Okay. So this organ failure, again there is this mod score, right? So you calculate the organ failure based upon Marshall's mod score. Okay. Again, which all organ is involved, based upon that there is a scoring.
Multiple organ.
Okay. Yeah. Continue. Then any other scores or anything?
So,
No.
Transcendence criteria is there.
Okay. What is that?
That is 0 hours, age is more than 55, WBC, blood glucose, LDH, and aspirate aminotransferase, 0 hours, and 48 hours, hematocrit, blood urea nitrogen, serum calcium, base deficit, and fluid sequestration.
Okay. Fine. That's all, no? Okay. So we will just quickly go through the etiologies also. So what are the common etiologies?
In acute pancreatitis, common etiology is most commonly gallstone.
So basically, if you look by Western literature, you will see that 50 to 60% is got to be gallbladder
stone.
and alcohol is lesser. But in our part of the world, we see pretty large number of alcohol-induced pancreatitis. Okay, so GB pathology, I mean obstructive kind of things. What is peculiar on that? Anything? Gallstone-induced pancreatitis.
Gallstone-induced pancreatitis is most commonly causing. Then in that condition, we can immediately do an ERCP to remove the gallstone.
You need to remember that ERCP itself can cause
iatrogenic pancreatitis.
That itself is one of the causes. Okay. For diagnosing gallstone-induced pancreatitis, what are the tools?
One is lefty we can do due to obstruction. We find an ALP showing in obstruction.
That is with the labs. Imaging wise,
USG abdomen.
Not pick up adequately if it is missing. There is endoscopic ultrasound is there. Okay, that will be one thing. If a transabdominal ultrasound is not picking up, then that will be the other kind of thing. Any role for MRI in diagnosis of acute pancreatitis? Okay, this is one situation where MRI is equally good as a CT. Or basically, if the patient has renal failure, you are not able to give by contrasting, MRI can also give you then equally good information. Okay, so pancreatitis, renal failure, definitely you can go with an MRI with contrast. Fine. Then
other etiologies, infections like mumps, measles, coxsackie virus, drugs like azathioprine, corticosteroids, estrogen.
Yeah, we told about those things. Yeah.
Hyperlipidemia, trauma, idiopathic, iatrogenic, ERCP, other surgery, post-surgical. Chronic pancreatitis, there is alcohol, nutritional, cystic fibrosis, hypercalcemia, and trauma.
Okay.
That's the etiology.
Right. Then
On
clinical examination?
Clinical examination, there is two important signs for acute pancreatitis. One is Cullen sign.
Okay, what is
that? Bluish discoloration with periumbilical area.
Okay, and
then is gray Turner sign, discoloration on the flanks area.
Okay, fine. Anything else you want to add? Okay, so we discussed about the etiology, we spoke about the clinical signs, we told about the investigations, right? The emergency management, the further investigations also, right? Based upon the etiology, we told about gallbladder pathologies, we told about alcoholic. The other thing which we usually miss is the triglyceride induced. Okay, again triglyceride induced pancreatitis, the management principles will change. Okay, there are certain specific things which is beneficial in triglyceridemic pancreatitis. What are they? What's the drug of choice? That is usually the medical measures, your fenofibrates definitely. Along with that, there is role for insulin and heparin. These two things have been proven to be useful in treating hypertriglyceridemic pancreatitis. Other thing is to go for plasma exchange. Okay, refractory to medical measures, then definitely there is role for plasma exchange in pancreatitis. Okay, now you have a patient admitted with acute severe pancreatitis into day 7, assuming and still the pain is persistent. What are the things you are going to consider at that point?
Seen as refractory pancreatitis, we do any imaging study for CTs.
Exactly. That is where definitely a CT with contrast will, we have to look at it to look for necrosis, any other collections. Okay, and that's a situation where your medical management may not be enough. Okay, probably we'll need to go for a drainage of percutaneous drainage or any other interventions to drain the collection will be needed. Okay, again into 2 weeks, still on broad spectrum antibiotics, still infective parameters are going up. That will be the time where you can consider empirical antifungals. Okay, this is the usual kind of timeline wise management. Acute severe pancreatitis not responding, imaging. If there is a need to drain, definitely drain it. Consider antibiotics, wait for the cultures. If the drainage is there, send the samples from the pus to look for which organism it is. Adjust the antibiotics according to the pus cultures. If still remaining refractory, cultures negative, but inflammatory markers are remaining high into 2 weeks plus, that is where you consider empirical antifungal. So that is the usual kind of a progression. And definitely surgical measures will come in if it is remaining refractory. Okay, anything else you want to add? So this is what we have limited our discussion specifically to adult acute pancreatitis. In pediatrics, things will be a little more different. In chronic pancreatitis also, things will be, there are certain other things also. Okay, fine. Anybody wants to add anything else? Nothing, no? Okay, right, thank you.
Thank you.